Good afternoon, everyone. My name is Ahmed Ibrahim. I'm with the Computer Science Department at the University of Kentucky in the USA. Today, I'm going to present an abstract architecture design for medical information exchange. In this presentation, I will first show the need and importance of electronic medical information exchange and the challenges for such process. Then, some relevant previous work on the security and privacy of exchanging medical information will be presented. After that, our proposed architecture design will be discussed. Lastly will be the future work and conclusion. Electronic health records are defined as a longitudinal collection of electronic health information about individual patients and populations. EHRs are increasingly becoming the way of storing information about patients like medication, allergies, lab results, and radiology images. Such records are usually stored locally within healthcare providers and are only accessible from within that specific healthcare provider's infrastructure. In 2009, the US government created an EHR incentive programs, which provides reimbursement to encourage healthcare providers to deploy and use EHR systems. Later on, the government also did set January 2015 as a deadline for healthcare providers to transition to EHR systems and announced that there will be penalties for those who do not successfully demonstrate meaningful use of EHRs by that date. The US Department of Health and Human Services developed two rules to accomplish the HIPAA requirement of 1996, which are the Privacy Rule and the Security Rule. The Privacy Rule declares a set of standards which describes how healthcare providers keep, store, protect, and share patients' health information. The Security Rule defines security standards to protect privacy of individuals' electronic protected health information. It specifically mentions the requirements of ensuring the confidentiality, integrity, and availability of all protected health information created, received, maintained, or transmitted. It also requires the identification and protection of electronic protected health information against anticipated threats to the security or integrity of the information. EHR systems are being widely used by various healthcare providers due to the benefits these systems offer. To increase efficiency in medical services and to provide complete and accurate medical information, interinstitutional EHRs are more and more used to accumulate and keep information on patients. EHR systems will absolutely save significant money and improve care and safety when connected and sharing clinical information. Measurable savings will be realized when systems allow for electronic transmission and translation of patient records across different systems. Shareability of the EHRs could also help save lives, enhance disease management, and achieve more efficient and effective medical research results. This slide here will show how the current medical information exchange happen. Assume there's a patient who used to live in North Carolina and Virginia before moving to Kentucky. The patient has been seen in both hospitals, H1 and H2, by physicians of different specialities. Now the patient wants to continue his healthcare healthcare with provider H3 in Kentucky, so he needs to authorize H3 to get a copy of his records from H1 and H2. The patient has to sign a consent form to release his medical information stored at both H1 and H2. The consent form is a general form that does not specify which medical information is being requested. H3 then has to fax the signed written consent to H1 and H2 and wait for the reply to be faxed back. Also, the process may include phone calls between involved parties to authenticate the initiating healthcare provider. After authentication, remote healthcare providers H1 and H2 faxes the patient's records back to H3. The process described has three main drawbacks. First, if the requesting healthcare provider and the provider holding requested medical information, such as H1 and H2, are operating normally, the patient will be required to wait until the medical information is received back. Second, the requesting healthcare provider will face a huge delay in getting the response back if there exists a time difference between communicating healthcare providers, or if the healthcare provider holding the requested medical information is not operating during the time of the request. In this case, a further appointment may need to be set up in order to be able to have all medical information available. Lastly, the signed written consent does not specify which medical information to be retrieved. Subsequently, disclosure of medical information that the patient did not want to share with the requesting healthcare provider is more likely to occur. Also, the consent can be used to retrieve medical information from healthcare providers other than those specified by the patient. One of the challenges towards having a medical information exchange environment is information silos or data lock-in. An information silo is created when a data system does not exchange data with other similar systems. Large hospitals tend to create information silos due to their willingness to share data internally and their lack of willingness to share data externally with other healthcare providers. Another big challenge for the electronic exchange of medical information is the security of such systems. The influx of new EHR coupled with more medical devices being connected to the internet has generated a rich new environment for cybercriminals to exploit. Cybercriminals sell partial medical information at a rate of $50 each on the black market compared to a $1 for a stolen social security number or credit card number. This shows that health information is more valuable to hackers than social security numbers or credit card numbers because health information have more extensive medical information about people, like prescriptions for controlled substances as an example. Researchers showed that more data breaches happen in the healthcare industry now than in any other sector. In 2015, an attack on Anthem, a health insurance company, exposed 80 million health records. An attack on Primera, another health insurance company, exposed 11 million health records. And an attack on the hospital of the University of California in Los Angeles exposed 4.5 million health records. A recent research shows that 64% of healthcare organizations experienced an external cyber attack during 2015. Summing up the last 5 years total, the Department of Health and Human Services found that over 143 million patient records were compromised, which corresponds to 45% of the American population. So, in order for any electronic exchange of medical information to meet the security standards defined in the technical safeguards of the HIPAA security rule, it has to satisfy and meet the following requirements. Authentication, which is the process of verification of identities between communicating parties. This means that healthcare providers must be able to authenticate each other as well as the involved patients electronically. Authorization, which is a requirement that allows healthcare providers to access only the medical information for which they have authorization, and any disclosure of patients' medical information without patients' permission must be prevented. Privacy, which means that information disclosure to any unauthorized parties must be prevented, and only authorized parties who have permission can access such information. Integrity, which means preserving data accuracy and consistency and detecting any unauthorized alteration or distortion of information. Finally, auditability, which implies recording activities applied to data in the order they appeared, such as access requests or data modification. You all presented a patient-centric content protection system that is based on tamper-resistant hardware. Smart cards were used for the identification and authentication of patients, healthcare providers, and support personnel. This work uses a specially designed hardware called Personalized Medical Recorder to interface with patient smart cards and the healthcare provider's smart cards in order to store the patient's protected EHR transactions. The infrastructure still provides PKI, public key infrastructure, the distribution of CRLs, and EHR backup. But the main drawback for this work is that each patient is required to have a smart card at the time of service, and that it requires the personalized media recorder hardware to be available at every healthcare provider. Hugh and others presented a contract-oriented e-health security architecture, which delegates the trust and security management to the medical service provider during the contract period of the treatment. This architecture consists of a smart card trust center that issues smart cards to patients and a medical center server that belongs to the place where a patient registers as the home medical service provider. They propose to store all the patient's encrypted EHRs and contract keys on the patient's smart card, but this is infeasible due to the limited storage capacity of smart cards. Also, in case the patient loses the smart card, all stored protected health information data and contract keys are lost, which may compromise the privacy of the patient. And the drawback of the smart card existence requirement still exists. Hess and others proposed a scheme to allow user-controlled disclosure of health data to third parties, which is divided into two subsystems, the data service and the patient service. Medical systems use the data service for storing and retrieving medical data. The patient service offers policy management, logging service, and verification service to the patient. It's used by patients to check the correct functioning of the data service, which puts a lot of burden on patients and requires patient training and continuous monitoring. The scheme proposed is not privacy protecting and does not enforce any obligations regarding medical data disclosure. Instead, an after-fact method was proposed to detect disclosures which did not meet patients' policy access rights. Vergara and others proposed creating on-demand trust relationships among medical institutions, healthcare record servers to authenticate requesters based on chains of trust. Trust servers validate the requester and query other nearby trust servers to retrieve a signed token corresponding to the health record server holding the patient's EHRs. When a trust server finds the required health record server, a signed identity token is returned to the requester, which can be presented to the health record server to access the needed records. One problem in this proposal is that the communication between the requester and the health record server is always done using the same unique symmetric key generated by the system for all communication, which makes the proposal not a secure solution for long-term implementation. Another drawback is that their approach contacts several parties to validate the identity of their requester, which will take much longer trust server hops to locate the correct trust server responsible for signing the identity token. Also, the identity token does not specify the type of medical information to be exchanged. From the previously presented samples of previous work, it's clear that the area of medical information exchange has been complex, expensive in terms of time and number of messages exchanged. It requires patience to maintain smart cards, it requires patience training, and no complete solutions have been proposed. After studying several previous work, we found that there is real need for an architecture design which can facilitate the development of simpler protocols with higher security. Here, we present an architecture design that specifies all of the major physical and logical components to allow the secure exchange of patients' medical information between different healthcare providers. The architecture components, which you will see, allow the development of protocols that can maintain the security standards defined in the technical safeguards of the HIPAA security rule. The general architecture of our design consists of 5 elements, which are the National Medical Certification Authority, that issues the second main element, which is X509 digital certificates, the healthcare providers, medical personnel, and patients. Our design does not require the usage of any special hardware by medical personnel or patients. We focus on the physical and logical design of the components carrying out the exchange process. The National Medical Certification Authority is capable of validating legitimate healthcare providers and issuing X509 digital certificates with all corresponding information for the registering healthcare provider. For the highest level of security, the NMCA does not generate the public-private key pair for healthcare providers. Instead, the healthcare providers are required to submit a valid public key during their registration and make sure to store the corresponding private key in a highly secure place. The National Medical Certification Authority infrastructure consists of a registration authority that acts as the verifier for the certificate authority before a digital certificate is issued to a requester, a certificate authority that issues and verifies X509 digital certificates, and of course X509 digital certificates which contain identity information for entities, a certificate repository database where the digital certificates are stored, a digital checker that runs the online certificate status protocol for providing the revocation status of issued digital certificates, and lastly is a certificate management system which provides the tools for the NMCA to perform. The National Medical Certificate Authority issues X509 digital certificates to each healthcare provider. These healthcare providers use their X509 digital certificates to establish authentication at the beginning of the communication process before exchanging patients' information and medical records. The extension field can be used to include either critical or non-critical indications. This gives healthcare providers the ability to include options for rejecting communication if they encounter an unrecognized critical extension. Healthcare providers are the most important component in the architecture as they retain patients' EHRs as well as information about medical personnel treating those patients. The healthcare provider's architecture consists of a communication gateway, an integration system, an EHR data system, and an audit system. The communication gateway stores the healthcare provider digital certificate received from the NMCA. It's responsible for setting up a secure communication with other healthcare providers. It handles mutual authentication with other healthcare providers, identifies patients, sets medical information type to be retrieved, and performs message exchange. Also, it updates the records in the audit system with corresponding actions. Excuse me. The integration system processes requests after the communication gateway finishes the authentication process. On the sender side, it removes all patients' identity information from the requested EHRs of the requested type, then integrates the remaining data in one medical information record. On the receiver side, it splits the medical information received back into separate EHRs and adds the patient's identity information, which the receiver already has, back to the EHRs. Also, it updates the records in the audit system with corresponding actions. The EHR data system is responsible for running queries to retrieve selected patients' EHR and adding new EHR for patients and handling internal encryption-decryption of stored EHRs. The audit system keeps a complete record for every incoming and outgoing request to ensure auditability in case of a breach. It receives data from the communication gateway and the integration system to build a complete transaction log. As future work, the proposed architecture design will be used as a foundation to develop secure medical information exchange protocols which comply with and maintain the technical safeguards of the HIPAA security rule. Protocols developed to run on the architecture must ensure mutual authentication between healthcare providers and patient authentication for home healthcare providers. These protocols should also allow communicating parties to exchange their digital certificates and verify the NMCA's digital signature in the received digital certificates. Confidentiality of medical information during transmission must be ensured using symmetric key encryption. The integrity of medical information must be maintained, and protocols should maintain an authorization requirement that ensures that patients have authorized a healthcare provider to retrieve a certain type of their own medical information from the provider holding such information. No other type of medical information should be exchanged other than the type authorized by patients. Currently, we are developing a protocol to run on the proposed architecture to secure medical information exchange. Protocols will be developed to simulate prototypes will be developed to simulate the protocols as a proof of concept using the GDK 8 with Java cryptography architecture and Java cryptography extension libraries to support the required encryption-decryption operations. Running and testing the prototype will be used to evaluate the developed protocol. As a conclusion of this presentation, the architecture design is in here is the simplest one proposed in comparison to the previously proposed architectures. It has the major physical and logical components required for developing any future protocol securing the exchange of medical information. The design allows different healthcare providers to authenticate each other to further perform patients' authentication to their home healthcare provider. It also establishes a structure to validate the type of requested medical information, computes a secure symmetric key for medical information exchange, maintain the privacy of patients, and ensure the confidentiality of exchanged medical information. Also, it does not require the usage of any special hardware or smart cards by the patient or healthcare providers, whereas the previous work presented earlier requires the usage of specially designed equipment like tamper-resistant hardware and smart cards. The audit system components allows for the maintenance of adequate information about each transaction by keeping records of all incoming and outgoing exchange requests for each healthcare provider. Any protocol can easily maintain auditability by running on the proposed architecture. The proposed architecture is a foundation that allows for the development of secure medical information exchange protocols that maintain the technical safeguards of the HIPAA security rule. Thank you very much for your time. Again, my name is Ahmed Ibrahim, and this is my email over here. Please feel free to contact me if you have any questions. Have a good rest of your day.